So now I would like to invite Dr. Saurabh sir, and he would be talking to us in choosing the right fit in Phakic IOLs.
Good morning, everyone. Thank you, Dr. Pooja, for inviting me in this IC. And I'll be speaking about the Phakic IL. And so this was the first IPCL, Phakic IL, which I did 10 years back. And the patient followed just few days back. And you can see how clear it is and well centered. So I think Phakic IL has transformed our refractive procedure for sure. So I will not go through the routine of Phakic because we already know. So I will just highlight the points where we can do something differently. So I think one of the things which I have noted in my practice is that most of these Phakic patients have very high myopic errors. And when the myopic error goes above say minus 15, 16, and particularly if patient have subnormal vision, say 618 or 624, the accurate refraction sometimes becomes a problem. So what I do in my practice, if the patient's vision is subnormal and with regular spectacles vision is not improving, then we do contact lens back calculation. So why this is important is because many times patient will have maybe similar vision. Say for example, patient is high myope. So between minus 18 to minus 20, patient may have similar vision because it's subnormal. And if we correct minus 18, sometime patient may land up with residual minus 2. And if we correct minus 20, patient may land up with residual plus power. So to avoid that, what we do is that we use contact lens, trial contact lens. If patient is wearing already, that's better. And then we do based on vertex distance, we do back calculation, so we get exact refractive error that the patient has. This is apart from the cycloplegic refraction that we, this is just for the beginners. Whenever we say ACD, for in case of phakic, it's always AD, that is the aqueous depth. So we have to subtract the corneal thickness from the ACD, which we have to remember when we are beginning these phakic. Now you can use various devices. Most of them are almost similar. Stick to one device whenever you are calculating. So generally you get a better idea. Now white to white, I think, is the only measurement that it has to be very accurate to have good, because vault is the final thing which determines the final success of our phakic. So we always prefer electronic calipers under the microscope, patient lying supine. And this is what something I want to talk in a short video. Apart from using digital calipers, what I do is that after doing the digital calipers, I just put it on a scale and check whether that correlates, because sometimes these digital calipers, the calibration may go wrong, because when we get it, the calibration is right, but over a period there might be some mechanical issues and we may have missed calibration. So this is best way to calibrate it ourselves. So this is a short video showing how to exactly take white to white diameter. And what is most important is to understand the surgical limbus, because we have variations in the surgical limbus of a patient. Sometimes patient have very wide surgical limbus, sometimes it's very narrow. So when we say white to white with respect to phakic, what we have to do is take it from the mid limbus and don't take it exactly white to white. So you can see here I am measuring it under the microscope. It's too short. You can see that it's not. And now I have increased the size, and you will find it is actually white to white. That means it's slightly bigger than the darker area. Just go ahead a bit. Yeah, okay. So this is actually white to white. You can see it's incorporating right from back, but it is bit large for the phakic. So in cases where there is a wider surgical limbus, what we have to do is take it from the mid limbus to mid limbus. Otherwise, we usually end up with the oversizing. Generally, once you take one eye is white to white, generally the rule is that other eye also has same white to white. So keep the same calipers as it is and measure it for the other eye. And as I showed earlier, so this is measuring of the fellow eye. Most of the times you don't have to change anything. Usually the white to white is similar. And after that, as I showed, just measure it on the scale to avoid any problems with the calibration of the calipers. UBM has been talked about a lot, but I think it has not improved accuracy any further. So I think we have to stick to digital calipers. Other devices also you can use. The advantage of using other devices is that you can have a correlation between white to white. So sometimes you don't have to see the white to white diameters measured by other equipment. Just do the digital caliper measurement, and generally in your equipment you will find there is a correlation. For example, what I find when I do the white to white with IL Master 700, And then with digital calipers, the digital calipers always give zero point 0.5 less white to white as compared to 700. And in case of cirrus, the HVID is almost similar. So if there is a mismatch between these readings, you can go back and again check the white to white. Now, in case of slit lamp examination and distant direct ophthalmoscopy is very important, because you should not miss early, signs of cataract, because some of these patients may have cataracts, and if you miss it preoperatively, postoperatively it may be a problem. So don't, take this. Make sure that you examine thoroughly. In some high myopes, there might be mild subluxation, so it makes sure that you examine these patients properly after full dilatation yourself, so as not to miss this kind of patients. Other tests preoperatively are very important. Now, before ordering the phakic, most important is reconfirm all the data, including the refraction, axis of cylinder, ACD, and white to white yourself before ordering, and recheck the phakic which is selected by the company. Double check. So this avoids many problems after the in the post-operative period. Now, during surgery, my tips are that do not do over-aggressive viscoelastic wash. I prefer a passive visco wash. The idea of passive visco wash, where I just flush out the viscoelastic from the anterior chamber, is that there should be very minimal fluctuation in the anterior chamber depth during phakic implantation, because we are dealing with very high myopes. The lesser the fluctuations of the anterior chamber during the surgery, lesser will be the post-operative retinal complication, because the post-operative retinal complication is because of acute PVD induced by the procedure. And basically, when you are implanting a phakic, it's like a trauma to the eye. Lesser the fluctuations in the anterior chamber during this period, lesser will be the chances of acute PVD, and lesser will be the retinal problems. The preferred viscoelastic is 2% HPMC. Of course, few do hydroimplantation as well, but the idea is to have least amount of anterior chamber fluctuation during the procedure. In the early part, I think it was advised, or maybe other phakic surgeons were using pilocarpine to do surgical PI, but it has to be absolutely avoided. This was my first case I did in 2013, and as usual, I did the surgical PI and put pilocarpine. I saw this patient 2 hours post-op and did a OCT. There was absolutely no wart, and it was very frightening to see that. So I just stopped. I saw the patient again next day. The wart was there. So it was the effect of the pilocarpine, which was pushing this phakic down to the anterior lens surface, and which I found out. So after the first case, I never used pilocarpine. What this pilocarpine does usually, though, is that it leaves these kind of deposits on the anterior lens surface. Most often, it disappears after a month or 2 months, 3 years. This is the same patient which had anterior deposits, but after 3 years, you can see it's clear. So it's reverses, but I think best to avoid pilocarpine. Same is true during intraoperative, maneuvers. Don't push the central part of the IPCL back on the anterior lens surface. That may leave these kind of changes for some period post-operatively. Now, few of the noted common complications which you can avoid by adjusting the post-operative regimen. We found, because these are high myopes, there are higher chances of being steroid responders. So there is no need to give post-operative steroids for more than 7 days in these patients, because there is hardly inflammation post-operatively. So after 7 days, just stop the topical steroids. You can continue with NSAIDs for some more time. Another thing, because many times companies say that if you have, say, small cylinder, say minus 0.5 or minus 0.75, you can neglect it and go for a spherical IPCL, because it will reduce the cost for the patient as well. But if you're dealing with smaller refractive errors, for example, if you have a patient, say very low CCT, and you have power of say minus 0.5 with minus 0.5 cylinder at 180, remember that your surgical induced astigmatism will be much higher, because patient already has low CCT. So it will not be usual 0.2, 0.3. I have seen that with lower CCT, SIA can be as high as 1 diopter. So what happens that if you use a spherical IPCL, in this case, patient will end up with residual cylinder. So as far as possible, go for a toric phakic IOLs. Now, one of the common things which is noted after phakic IOLs, particularly in very high myopes, is that patient may have accommodation paralysis. So generally, patient will come back after a week and say that I cannot read clearly, though the distance vision is clear. What I have seen is that it recovers usually in 2 to 3 weeks. There is no need to worry. Just wait for some time and it will recover. So that has to be told to the patient. Checking the wart. we can, if you don't have, nowadays everyone has OCT, so that is the best way to do. But if you don't have, you can use the slit. Now regarding sizing, because this is the most important part, the perfect size has been told to be between 300 to 700 micron, but generally what I do, I target 500 to 1000 microns. The reason is that with higher volt, there is lesser chances of IOL rotation. That's what I have seen. Lesser chances of cataract. And remember that every year the volt reduces by around 10 to 20 micron. It may vary patient to patient. So if you see after 10 years, the volt is going to be reduced by 150 to 200 micron. So suppose you have volt in a phakic IOL patient of 400 or less, patient invariably is going to have lower volt over a period of time. These are the patients who land up with higher chances of cataract formation. So my choice is to go for little higher volt. Now for sizing, as you know that the same eye, if you use a larger size of phakic IOL, it's going to go for a higher volt, and lower size goes for a lower volt. So if you see the calculator used for phakic IOL, there are a couple of things this affects. One most important thing is white to white, so you have to be very accurate with that. Second thing, also the ACD changes the size of the IPCL that is required. Here, both the, if you can see clearly, both these measurements, the rest of the things are same, except that ACD is low in one patient, 3, and ACD is 4 in another. And the change in the size of the suggested IPCL is of by 0.5 millimeter. So remember that also changes the size of the phakic IOL that we are going to use. Apart from that, even the keratometry changes the size. So the same patient, same similar other things, but keratometry you can see has jumped from 43 to 47, and the size has jumped from by 0.5 millimeter. So if you are not very careful about entering all this data, you may land up with errors. Now same thing, what happens is in keratoconus, where there is erroneously very high AC keratometry, which the software interprets as high ACD, but actually it is only the central ACD which is high, but peripherally it may be a normal ACD, and you may land up with oversizing of the phakic IOL in keratoconus. So in these patients, you have to be specific, customized, and you may have to go for a slightly lower size IOL, IPCL, phakic IOL. Apart from that, always check whether patient is going to use the scleral contact lenses after using the phakic IOL. If you are just debulking the spherical part of the refractive error, it is better to use just a spherical phakic IOL rather than a toric, because if patient uses a scleral contact lens after a toric phakic IOL, patient will have to use a cylindrical correction over the scleral contact lens. So that has to be determined before you plan for the surgery. Now I'll just skip through. I prefer one eye at a time because I want to see the world. I will just give an example of these twin sisters which I had operated. Both had same refraction, same refractive error. All things were same except white to white was 11.2 in one patient and another 11.4. So in the first twin sister, I used a phakic IOL which was selected by 1.3 millimeter difference. I got a 1300 micron volt. Waited for 3 days, it reduced to 900, so which was good. And then for fellow eye, I order a lens which is 0.25 lesser, so I got a volt of. So remember, for every 100 micron decrease in the size of the phakic IOL, you expect 40 micron decrease in the volt, and you can calculate it accordingly. But for the other sister, 11.4 was the white to white which was measured, and we went for a higher size 1.35 millimeter difference, and we landed it with very high volt which I had to replace. So I went for a 0.5 millimeter smaller phakic IOL, and as the rule, 200 to 300 micron volt was reduced. So always avoid phakic IOL larger than 1.2 millimeter. Otherwise, you have to think a lot whether you want to go for that or not. Now there is an advantage with IPCL because the difference in sizes is just 0.25 millimeter. So you have a lot of things you can vary. Another thing which you can study further is that what I have seen is that most of the high myopes, though we have this general conception that after 18 generally the axial length stops increasing and the myopia stops progressing. But if you look at the patients who have got 26.5 or higher axial length, it continues to increase till the age of 27, 28 as well. And that may be one of the causes that post-phakic IOL in high myop patient may land up with myopia after 2, 3 years. So what I generally do in patients who have very high axial length, I use this algorithm where less than 23 I overcorrect by 1.5, 23 to 20 1 and then by 0.5. So this is my personal nomogram which I use. You can try it and it will be useful. Thank you so much, Pooja.